Okay, right, this is our inaugural workshop with T4 Physio, and today we're going to be looking at a shoulder workshop, so I'll let Emma take it away.
So today we're looking at the shoulder, so just a quick quiz for you to begin with, only one question though. So how many bones do you think that there are in the shoulder?
One.
There's actually 3. So it's made up of the clavicle, which is your collarbone, the scapula, which is obviously a big bone at the back, which most people think is the kind of full joint, and then your humerus, which is your arm bone. So the shoulder itself is actually the joint, rather than just say the scapula just straight at the back. So then the shoulder joint. It's a ball and socket joint, which is made up of the humerus and the scapula. It's a synovial joint, which means that it's a joint that has cartilage. The head of the humerus is much larger than the socket, which gives it a lot more movement, but it makes it a lot less stable. So because of the synovial membrane, it lines the kind of inner surface of the joint capsule, so that on the inside, and it helps with producing the synovial fluid, which reduces the friction within the joint, so it makes it a lot easier for it to kind of glide when it's moving. It also has a bursa, which is a kind of sac that's filled with the synovial fluid, and that helps with keeping the tendons from kind of rubbing over the joint structures and into the bones or anything like that. And it's also got ligaments that help provide some of that stabilisation of the bony structures as well. So as we said, it's quite a mobile joint, and it's one of the most mobile in the body, which we're saying is at the expense of its stability. So the factors that contribute to the mobility is the type of joint that it is, which is a ball and socket joint, the bony surfaces and the laxity of the joint capsules. And then the movements at the shoulder are extension, which is the one way you go back, flexion, which is all the way up, then abduction, which is to the side, and adduction, which is down, but then also it rotates. So as you can tell, that's quite a lot of movements for one kind of joint to be doing. So some of the things that help with the stability in the shoulder are the rotator cuff muscles. These are the subscapularis, which is a muscle that sits kind of underneath your shoulder blade, so it's quite a painful one ever getting kind of massage or anything like that, kind of under your armpits and into the shoulder blade. The supraspinatus, which is the muscle along the top. Then you've got the infraspinatus, which is the muscle that's more kind of on your shoulder blade, which can be quite painful as well. And as well as the teres minor, which is the one that kind of attaches right into the joint, and when you're pressing in that again, massage is quite painful. But these help to surround the shoulder and fuse with the joint capsule, and it helps to keep that humeral head into the shoulder joint and keep it more kind of stable. So if you're having problems with your rotator cuff muscles, that's where you're going to get some of that pain and that kind of laxity that you start to feel. There's also the glenoid labrum. This is a kind of cartilaginous ridge which is around the kind of arc in your shoulder, and or the socket, and it helps with deepening the cavity, so it creates more of a kind of seal and kind of suction with keeping the head into the humerus head into the joint socket. But then you can, if you have any damage to that, it can cause kind of dislocations or anything like that as well. And as well as the ligaments, which kind of act with reinforcing the kind of joint. So that's why when people say, you know, if you've got kind of ligament damage, it can be sometimes the last thing that's happened in the injury. So just looking at a couple of different types of injuries now. So we have rotator cuff tendinopathy. So this is one of the most common causes of shoulder pain, and it's seen in about 30% of the population of people with shoulder pain. So that's quite a high percentage really, because you normally get, you know, odd ones where it's a couple of percent in the population. So there's some kind of occupational risk factors which can kind of lead to rotator cuff tendinopathy, such as awkward postures or staying in one position, heavy work or direct load bearing, repetitive arm movements, and working with your hands and your arms above shoulder height, because you're constantly in that kind of upward position, it's compressing into the joint, and that's where all your rotator cuff tendons seem to kind of lie. Some of the risk factors in general for tendinopathy are kind of muscle imbalances, because then other muscles are kind of working harder than another muscle. So say if half of your rotator cuff muscles are working harder, the other half are kind of laxing around, and then they've got that extra load on the tendon compared to the other ones, which should be taking up some of the force. As well as decreased flexibility. If you're overweight or with advancing age, and in certain sports such as swimming, a lot of repetitive arm movements, you're constantly putting your arm through the motion, you're going to get that kind of increase in stress, increase in kind of tension on the joint as well. Some of the symptoms that can occur with rotator cuff tendinopathy are kind of pain in the area of the rotator cuff tendon, so that's again right into the kind of joint. Tenderness in the shoulder joint, a dull ache with any kind of overhead reaching behind your back, lifting up, or anything with sleeping on that affected side as well, because you're putting that pressure onto the joint and closing it up again, as well as a kind of growing weakness in the shoulder. So once them tendons start being kind of irritated or anything like that, they're not going to hold the strength in the same way that they should be doing. So a little bit more on the rotator cuff tendinopathy. So you have kind of the extrinsic factors. So this is things like where you've got the compression on the rotator cuff tendon, like we were just saying. So it creates a lot less kind of joint space for them to be moving more effectively. Some of these can be because of decreased flexibility in the posterior shoulder, so that kind of tenseness means that your joint can't move effectively, and it means that you're not going to get that kind of stretch and relaxing which you should do normally with the muscle movement. Any kind of anatomical variants, such as kind of bony spurs, so some people can naturally be born with kind of hooked shoulders, so they've got kind of a bit of an extra bit of bone added onto the kind of socket, and that can then end up rubbing onto the tendons and causing quite a lot of pain and irritation to it. As well as scapular muscle deficits, again like we were saying, not taking up the work that they should be doing, puts pressure on other muscles, and as well as decreased flexibility in the chest. So again, tightness causes you to work harder in other places, and it's too much load for your tendons to kind of be taken. Then also there's the intrinsic factors. These can be due to kind of rotator cuff degradation with kind of the tensile or the shear loading, so again kind of that kind of rubbing or quite a lot of force going through it, so lifting anything heavy or anything like that. These can kind of alter the biology and the mechanical properties, as well as the kind of muscle morphology, so how it's kind of made up a little bit. So some of these can be, if you've had, say, a direct trauma, it can be due to your age or genetics, even poor biomechanics. So again, if you're in that poor posture position, you're forward, you're not using the muscles in the correct way for you to then keep your shoulders back so that it's moving properly. Overuse injuries and an increase in load on the tendon as well. Say if you've gone from doing no exercise to all of a sudden you're at the gym 7 days a week, lifting everything over your head, it's going to put that extra pressure onto the tendon, and your tendon's not going to be able to take it because it's not gradually been increased. So another kind of injury or condition that we can get is shoulder impingement. Again, this is quite a common cause of shoulder pain. When your arm's above shoulder height, the space in the joint kind of narrows, and it's kind of like this picture shows. You can see where it puts that kind of pinching onto where the tendons are, and you get that kind of pinch feeling in the joint. Some of the symptoms of this can be kind of the pain in the top or outer side of the shoulder, pain when you're lifting your arm over because again creating less space, or even pain and aching at night, which could affect your sleep, and even possibly a weakness in your arm. This can be because where your tendons are attaching with your biceps, they attach into the front of your kind of shoulder joint. So if you've not got that space for it to be able to move freely, you're pinching onto it, and that can cause that weakness where you can't feel as if you can move your arm in the most effective way. Moving on to slap tears and lesions. So this is an injury to the glenoid labrum, which is what we were saying before, helps to deepen the kind of cavity of the joint to help with that kind of suction that goes in. SLAP stands for superior labrum anterior and posterior, so that's more kind of into the positioning of where it is. Some of the different types of causes of this can be repetitive throwing, hyperextension, kind of a fall on an outstretched hand, heavy lifting, or even a direct trauma. Sometimes it can be caused by dislocations as well, so it's that kind of really big trauma that can just kind of rip it in a way, in a easier terms in a way. So there's 4 different types of the SLAP lesions. So there's type 1, which is more degenerative, so that would be more something to do with kind of the repetitive throwing. It's something that's kind of occurred over a number of years. Say if you're really into, cricket, you're constantly doing that swing around, which then causes that kind of constant kind of wear and tear onto the kind of labrum. But that means that there's no kind of detachments in the biceps tendon. So this is where the biceps tendon goes into the glenoid labrum there. Type 2 is kind of the most common type. So that's where there's a detachment of the superior labrum and of the biceps from the glenoid rim. So this means it comes more away. There's type 3, which is a bucket handle tear of the labrum, which intact biceps. So your biceps are still there, they're still connected into the joint, but it just means that there's been that tear into the kind of slap positioning. And then there is type 4, which is the least common type, and it's a tear of the biceps tendon with the bucket handle tear into the labrum as well. So again, these can all be caused by the different things, such as kind of the direct traumas, and it's all really dependent on kind of what's happened in the initial injury before you can find out what this is. But a lot of this you wouldn't be able to tell properly until you've had a full scan for it as well. So you'd know that you'd have it because you'd be there in pain, and it'd be kind of leading to it with the trauma and the type of subjective history beforehand as well. So then some of the symptoms of this can be sensations of clicking and popping, which are quite painful. A loss of movement up to the inside, so any kind of inside movement like this, it just puts that pressure onto the glenoid labrum, which if you've got a tear or anything like that, it's just that pain straight away because you're moving where your humeral head is just kind of rubbing onto the labrum like that, so it can feel quite uncomfortable. Pain with kind of overhead movements as well, because again you're lifting your arm up. It's because of that ball and socket joint, you're constantly moving through the motions of it. So if you're going upwards, if you're going round, that's why you've got so much movement, but it makes all movements kind of painful, is the thing. A loss of rotator cuff muscular strength and endurance. So again, because you're not being able to move your arm how you want to be doing, your muscles are going to weaken. And also inability to kind of lie on that affected shoulder as well, because again, pain straight onto the joint. So next we'll be moving on to frozen shoulder. This is sometimes called adhesive capsulitis, if you can get the words out, or a painful stiff shoulder. Most people know it as frozen shoulder. You can't move your arm and people just are kind of stuck in that position. It's an inflammatory condition. So it causes the kind of thickening and scarring of the tissue at the joint, and then this then leads to that stiffness and restricted movement. You can have either kind of the two types, which is like primary, which the onset is generally kind of comes on for no reason whatsoever in a way, and it just kind of something that gradually occurs, whereas with secondary, it can be from kind of a known cause. People who've kind of had surgery, they've been then stuck in kind of one position or anything like that, it can just cause that kind of restriction on the loss of movement that goes with it. Again, kind of most prevalent in women and people between 35 and 65 years old, and kind of more often in diabetic patients as well. There's kind of three different phases or types. They're not necessarily moving, straight through. You can be starting at one and move right to the other, or you can just stick in one and just see it out to the end of it. So the first kind of one that we'll talk about is the acute, freezing or painful stage. This is kind of a gradual onset of shoulder pain at rest, and you can kind of have sharp pains with any extreme movements. So if you're moving something quick, say if you're going to try and catch a ball or you're trying to get something really quickly, you're going to get that really sharp pain into the shoulder and you're not going to want to really move it then. You can have a lot of pain at night with kind of interruptions with your sleep as well. This could last between 2 to 9 months. So frozen shoulder is one of them kind of conditions that does last quite a while, and that's what can make it quite frustrating, because obviously everyone's waiting for the pain to start subsiding and the movement to be increasing, but it just takes time for you to gradually improve that. So the next one we'll talk about is adhesive frozen stiffening phase. The pain can start to subside, but there's still that loss of the joint movement. The pain's getting less, but you're still not able to, get your arm all the way up or all the way out to the front or anything like that. And it can occur again for between 4 months and can last until about 12 months as well. So again, very kind of long process with frozen shoulder. And then the last kind of stage is the resolution and thawing stage. This can just be really spontaneous. It can happen just all of a sudden. One night you can kind of been doing your exercises or anything like that, it's still really stiff and you're not too sure, whether it's going to be getting better. And because you're trying to increase that movement, it can all of a sudden kind of just click in a way that it's just like, right, this is starting to go, so that it's getting it, and it's just that progressive kind of increase in the movement. But once you've had, if you're stuck in one position for ages, you're going to notice, aren't you, straight away if you can lift your arm up or anything like that. So it really can be quite spontaneous, but it can last kind of up to 5 months, 24 months. So again, 2 years is quite a long time really for you to be in pain with no movement or anything like that. And then some of the kind of characteristics of frozen shoulder, oh gosh, too far, are the kind of gradual onset. So again, if it's, say, is gradual onset, or if you've had, say, surgery or anything like that, it can still be gradual, but if you, say, had surgery on your hand or anything, you're not going to be moving it to begin with anyway, so you'll be still thinking, you can move your shoulder and everything because you're keeping one thing so still. You don't always notice it, so it can just seem as if it's all of a sudden starting to come on. Kind of a progressive increase in pain as it's starting to kind of tighten everything up around it. A gradual decrease in the movement and loss of kind of external rotation, so again that kind of in and out and putting your arm behind your back and things like that will just be kind of quite difficult for you to do, as well as difficulty with kind of grooming, performing overhead activities, dressing and fastening items behind your back. So again, that upward movement is really restricted because you're putting that pressure into the joint to get it to be moving forward for you. So again, it can be really quite painful and something that lasts quite a while. But there is sometimes that way that you're thinking, like, right, am I ever going to get better? But then, if you're trying to keep it moving and that type of thing, there is a way out in some cases. You might never get kind of the full movement back or anything like that, but if you increase your movement so that you're more functional, that's kind of the main thing that you kind of look for with stuff like that as well. And then any questions?
Have you got an Ellie?
There's a few.
List her off.
Let me think. Right. So, do you have to? Can you know the problems with shoulders? Do you have to have scans? One of us has to have a scan. Can you diagnose problems without scans?
Yeah.
Or is it always best to have a scan?
The thing with like shoulders in general is because it's such a kind of compact joint, you can kind of be led towards, say, one diagnosis,
right.
And that's what you can kind of then work on, because they're all quite similar in ways where you're looking at overhead activities and that type of stuff. You're going to still want to look at aiming to get the same things going.
Right.
Scans will give you that kind of clearer view for definite what it is, but you can kind of, with physio and kind of looking at the different special tests, you can be led down the right path as well. Obviously we've not got kind of the x-ray vision or MRI vision or anything like that, so we'll never know for definite, say if we said to you like, right, yeah, you've got, slap tears, we'll not know specific, but we'll be able to tell that that's something that it'd be kind of, your symptoms would be kind of legional.
Due to the way I can move and
exactly,
the way.
yeah.
Can you have two of them at the same time? Like, the first two, sorry, the
tendinopathy and the impingement.
Yeah, can you have both at the same time?
Yeah, you can do, because they can kind of lead one into the other is the thing. So where you've got that kind of irritation with the tendinopathy, because it's so irritated, inflamed and swollen, it can feel that impingement as well. So that's what I'm saying, where they lead into each other in a way, in that they're all really similar. So if you've got one, then you could be likely to kind of have the others, but that's why it's kind of about addressing everything to do with the shoulder. Whereas, people will come in and be like, oh, why have I got this pain here, and you're doing stuff to say the front or the back or something like that.
That was like what I was leading up to, because from what I originally came from, is I'm doing different things.
Exactly.
But I understand it's a full, you got to think of the bigger picture, not just the tiny.
Yeah. So it's about kind of correcting that posture to then create that more space in the joints, that say if you have got tendinopathy or impingement, you've got more room for your tendons to be moving more effectively and kind of smoother.
Right.
So it's just kind of leading into each other like that.
I've noticed weakness on the left shoulder, but I'm having the pain, but now you've explained that it's due to the tightness and the impingement, and you won't think that affect my bicep.
That's it, yeah.
Because it's your shoulder.
Exactly.
But because it goes up.
It attaches the whole way in as well, so then it can affect it in the same way, yeah.
Due to the way it clamps, or why?
In a way, yeah.
You wouldn't think.
So because the biceps tendon, it attaches right into the shoulder joint. So like we're saying, where it's kind of moving all around and everything. If you've got that kind of inflammation and everything, so kind of large, it's a small joint. So as soon as you've got the inflammation, everything's kind of compressed. So that's where you're getting that kind of weakness that goes into your bicep, because everything around the biceps tendon is just so kind of tight in. So it's not kind of moving in a way where you can kind of contract and relax your biceps in a way where you'd normally be able to.
Is that due to, like today, I was like doing the bicep because I was in pain? Is that, am I weaker because my brain's saying you don't do it because you're in pain, or is it weaker because like physically?
I mean, it can be a bit of both, to be honest, because it kind of, they do play into each other.
Right.
But it can be, yeah, your brain's telling you you're in pain, so that's when you're supposed to kind of think, right, do I need to be doing this? Is there a way that I can do this where I'm not in pain?
Yeah.
And that's what I was trying to kind of force you to do, so that you're not trying to make anything more kind of irritated as well.
Right. Are they all fixable?
They can be. They can get to a certain point where it's kind of, you're more functional and less in pain. Stuff like tendinopathies can kind of flare up, and come kind of back and forth again with kind of impingement as well. But if you're kind of keeping on top of, you know, your exercises, keeping everything going, keeping your posture up and your tightness down, it can be stuff that you can control. So if you do get a flare up, you know exactly what to be doing to kind of stop that flare up. So you will kind of get the flare ups, because everyone's going to forget sometimes, like, oh yeah, you're going to sit there like this, and then your posture's going to be rubbish. But it's something where you'll know, like, right, you need to set your posture right, you've got that space in the joint again, and that's when you can work from there so that it's feeling better and more functional again after that.
Once you get it the first time, are you always prone to get it again? Like, I'm sure some people never ever get shoulder problems.
Yeah.
And then some people like myself have one.
Yeah.
Am I now prone to keep getting shoulder pain?
You could be, if you don't kind of keep up with your kind of maintenance of it. So keeping up with the little exercises that you wouldn't necessarily think about at the gym or anything like that. If you're keeping up with them type of things, you're keeping your shoulders nice and strong in the position that they should be. Because a lot of people, you know, especially like yourself, you go to the gym and everything, people aren't always thinking about the little movements in your shoulder.
No, that's what I'm
to be keeping it nice and kind of tight and the posture right, whereas everyone's thinking about your big compound lifts, you know, your deadlifts, all this. But you need to be doing the kind of the little ones for all the kind of smaller muscles around the joint to keep it protected.
It's just my left shoulder. Is it always one shoulder? Do people ever come in with both shoulders?
Yeah, definitely. Because you can end up, say, if one shoulder is, you know, quite irritable, you put all your pressure onto the other shoulder. So then you start sorting out this shoulder and like, oh, the other one started kind of flaring up a little bit now because you're putting all that extra kind of force through it, the weight through it. You know, if people are sore in, say, the left side, you're not going to want to use your left side, are you, straight away? So you're putting everything through the right side. So then you're increasing your load, you're increasing that kind of repetitive movements with it. So it can be that it's both, but it could also be not. It's just really person dependent, to be honest.
The exercise I'm doing on my left shoulder, because that's the injured shoulder, should I be doing them on my right shoulder because it's not injured?
Yeah. If you do them on both shoulders, you've still got to keep them muscles so that they're kind of even on both sides. So we definitely say do them on both sides to keep it nice and even. Although one side might be slightly weaker than the other, they'll still both benefit from it.
Why would one shoulder go and not the other? Why? If I've always been doing what I've done all my life, and obviously I've been using muscles wrong in both sides, why did my left side give way than the right side?
It could just be anything random. You know, if you kind of one side more dominant than the other, like say if you're right-handed, you know, you're using that more, you've got stronger in that muscle, and then something is kind of just gone in your left shoulder. It could really be just as simple as you're like 1% weaker in one side than the other, and it just causes it, yeah.
Okay, because I'm right-handed, so that would make sense.
Yeah.
I think that's it.
Yeah.
I think that's it.
You've pretty much answered a lot of that with the questions that you've done. But Lee goes to the gym, I don't go to the gym.
Yeah.
Yeah? How often often should I be doing my exercises and how far should I take my exercises?
Yeah. So I'd definitely say with doing your exercises, even if you're just doing them every other day, gives yourself time then to have the rest in between, and you're still just kind of going to just keeping on top of it, keeping the maintenance going with the exercises, so that you're just constantly keeping on top of it. Like I say, you don't want to then kind of lax off, because you'll notice the difference in that way.
And then once I've sort of come to the, I'm going to say to the end, but obviously I'm not going to come to the end because I'm going to do them all the time with my exercises. Do I then make them into more of a strengthening exercise, or do I just carry on as a continuous?
Yeah, so like when you get towards kind of the end where it is, you know, you're feeling a lot better, then that's when you're wanting to keep the kind of more strength-based exercises going, because that's where you're going to keep that kind of flare-ups down to a minimum, because you're keeping the muscle nice and strong. Whereas if you just kind of lapse off and don't do as much, or do a lot kind of lower kind of reps or anything like that, you're not keeping the muscle as strong as you want it to be kind of most effective and most pain-free.
And my last one, you know how you saying like about the bowling at cricket?
Yeah.
So could I cause myself any injuries by doing something repetitive too much?
Yeah, I mean, you could do in some ways. More with that, it's, you know, they're doing it quite fast with the bowling and the cricket, but just doing something repetitively in kind of the wrong position is where you're going to get the most kind of problems with it. You know, if you know, everyone's going to do kind of the repetitive movements anyways, and you know, as you get kind of older, you're going to get general wear and tear anyway. But if you can avoid that by keeping that kind of proper posture, your shoulders back, then you hopefully be kind of less likely to be in pain and less functional from it. So it's just about kind of keeping the right positioning while you're doing anything repetitive, so that you kind of decreasing your chances of being painful or anything like that.
Super, thank you.
So, one last, so it's a lifetime now that I'm going to have to keep on top of this shoulder to maximum, to minimise me getting a reoccurrence.
Exactly, yeah. And it's just kind of, you know, like we were saying, even to be fair with you, if you get to a certain point where you're more kind of pain-free and functional, even if you're just doing it a couple of times a week, you're still keeping on top of that muscle strength to be keeping it nice and stable.
Okay. Thank you very much.
Thank you.
It's alright.
That was our Facebook Live for the shoulder workshop. Join us again soon for future workshops. Bye.